Welcome to OCRA's Gynecologic Cancer Updates from the spring 2025 SGO and ASCO meetings. My name is Mette Buhl. I am OCRA Senior Director of Treatment Access and Scientific Education. And I'm thrilled today to have my friend, Dr. Ramez Eskander, a gynecologic oncologist at the UC San Diego Morris Cancer Center. Welcome, Ramez, and thank you for taking time to come here to talk about some of these interesting results that were presented earlier in the year.
Thank you, Mette. Thank you for having me. It's a pleasure to join you. I am excited to discuss this data from both the ASCO annual meeting as well as touch on some of the SGO data. It's an exciting time.
Agree. Let's get started. See if I can move to the first slide. So for the first part of this conversation, we are going to talk about the use of immune checkpoint inhibitor in first-line treatment of gynecologic cancers. And at the ASCO meeting, we saw the final overall survival data from this Keynote A18 study in cervical cancer. Can you help us understand what they found?
Of course. So this was actually very exciting. Why? Because for many years, actually almost a quarter century, the standard of care for treating locally advanced cervical cancer was concurrent chemoradiation, meaning you deliver radiation and you do weekly chemotherapy at a lower dose to act as a radiation sensitizer, but it also has anti-cancer effects. And we know that cervical cancer, the vast majority are HPV-associated
Hmm.
malignancies. And so the thought was, well, if this is a malignancy that's linked to exposure to a viral etiology, could it also be susceptible to immunotherapy, capitalizing the body's own immune system to improve clinical outcomes? So this was a very large clinical trial, over 1,000 patients
Hmm.
randomized to standard of care concurrent chemoradiation with pembrolizumab, followed by pembrolizumab maintenance for 15 cycles, or concurrent chemoradiation placebo and maintenance placebo. And what was really provocative, and what we'll see on the following slides, is that the conduct of this clinical trial and the completion, the data showed an improvement in both progression-free survival and overall survival in patients with stage 3 or stage 4A locally advanced cervical carcinoma. And this ushered in an FDA approval for this
Exciting.
treatment regimen in the United States. So now in patients who have FIGO 2014 stage 3 or 4A cervical cancer, we can use radiation with concurrent chemotherapy and immunotherapy with pembrolizumab, followed by pembrolizumab maintenance because of the improvement in cancer outcome. And this really was the first meaningful change in the paradigm of treatment for locally advanced cervical cancer over the last, like I said, nearly 20 or 25 years. So a
Impressive.
dramatic, what we see as a dramatic accomplishment in an area where we continue to have an unmet need, particularly globally, but even here in the United States with cervical cancer.
Exciting. That's very exciting and rewarding when something can change according to a trial. And I know that you were also very involved. You're the PI in one of the large trials that investigated adding immune checkpoint inhibitor to first-line treating of endometrial cancer. Can you just kind of like explain have we found and what has happened in the endometrial cancer space?
Yeah, it's been a dynamic time with a lot of change, actually. And I know we have limited time, so we
Yeah.
can't go into too much depth, but just to touch on it briefly, initially, we had approval of immunotherapy in endometrial cancer for patients who had a specific biomarker, mismatch repair deficiency or MSI high,
Hmm.
after prior systemic treatment, meaning they received therapy and recurred. And then we had another large clinical trial that was led by Vicky Macker and colleagues that looked at a combination of an oral pill, lenvatinib, plus immunotherapy, pembrolizumab, again in the recurrent setting, meaning you received prior chemotherapy and then recurred. But then we had several large clinical trials, both in the United States and internationally, that looked at chemotherapy plus immunotherapy with immunotherapy maintenance in
Hmm.
patients who had advanced stage metastatic or recurrent disease. And what we saw is adding chemotherapy to immunotherapy improved progression-free survival and resulted in what appeared to be a trend towards improved overall survival.
Hmm.
And that's irrespective of the presence or absence of that biomarker of mismatch repair deficiency. So now in the United States, for patients who have advanced stage metastatic and or recurrent endometrial cancer, whether they receive prior therapy or not, we now have the ability to treat patients with chemotherapy plus immunotherapy with immunotherapy maintenance because of these improved outcomes. And we're eager to continue to improve on this. And there are many active studies, some of which we'll touch on, but it was really a paradigm shift in how we treat these malignancies.
To bring that immune checkpoint inhibitor treatment into the first line. Yeah.
Correct.
And now we're going to look in the ovarian cancer space because we don't yet, at least before this spring, we didn't really understand what do we do here. And also in ovarian cancer, we have also had some very large studies trying to find out, does it make sense to add immune checkpoint inhibitor treatment to carboplatin paclitaxel? So at earlier this spring, actually even before SGO, but also at SGO, we did see some results being presented for the trial called the KeyLink study. And this was a large phase 3 trial again that enrolled people with advanced ovarian cancer, only people without BRCA mutations in this case. And the people were treated in the control group with carboplatin paclitaxel. Bevacizumab was allowed, but it was not required. Then they had an arm where they added pembrolizumab to try and see if the immune checkpoint inhibitor could add a benefit for this patient. So the people that would get carboplatin paclitaxel with pembrolizumab in the treatment phase and then continue pembrolizumab as maintenance treatment. And finally, the third arm in the KeyLink study looked at carboplatin paclitaxel with pembrolizumab treatment, but then a combination of pembrolizumab with the PARP inhibitor olaparib as maintenance treatment. So that is one of the studies. There's a second study that kind of tried to address the same issue called the FIRST study. And we heard the presentation of those results at the ASCO meeting. The idea is kind of the same here. We're again talking about advanced ovarian cancer, advanced epithelial ovarian cancer. When the trial was initiated, it had 3 arms. Just like the KeyLink study, it had a carboplatin paclitaxel arm where bevacizumab was allowed. And then it had a second arm where it was a combination of carboplatin paclitaxel with PARP inhibitor. In this case, it was the PARP inhibitor niraparib maintenance. And then the third arm, the experimental arm here, was the carboplatin paclitaxel with the addition of an immune checkpoint inhibitor called dostarlimab. And then maintenance treatment with a combination of the immune checkpoint inhibitor dostarlimab and niraparib. These large phase 3 trials take a long time to basically happen. And this trial actually started before we even had the approval of PARP inhibitors as maintenance treatment in the first line setting. So the first trial had already planned on if that was going to happen, they would close the arm without PARP inhibitor maintenance treatment. So in the end, the first trial really became a trial that studied as a control arm carboplatin paclitaxel with niraparib maintenance, and the experimental arm was then the addition of the immune checkpoint inhibitor dostarlimab. So at these meetings, we actually learned that both KeyLink 001 and FIRST met what we called the primary endpoint, which was that in the case of KeyLink, we saw that the combination of olaparib and pembrolizumab maintenance and also pembrolizumab in treatment resulted in much better PFS than the control arm, which in this case was compared to the carboplatin paclitaxel arm. However, we did not see signs of overall survival difference, and we also found that the benefit actually was seen regardless of the patient's PD-L1 status. In the first trial, where we had a comparison between an arm where we had a PARP inhibitor maintenance treatment to an experimental arm where we had PARP inhibitor together with immune checkpoint inhibitor, we did also see a PFS improvement, but much more modest. And again, we saw no overall survival differences, and also they did not see that this improvement was actually dependent on the patient's PD-L1 status. So what do we make of this? Help us understand what this means.
Goodness, this is
Yes.
so nuanced. And I will just say, this is where, as you alluded to, Anameta, the design of the study and the time in which the study was conducted can sometimes make it difficult to interpret the data at completion of the trial. And the reason that I say that is if we look back at the schemas, or the design of the studies. We also know that since these trials were designed and conducted, we also have a new FDA-approved treatment options for patients with advanced stage ovarian cancer, and that's the combination of a maintenance PARP inhibitor
Yeah.
with bevacizumab.
Mm-hmm.
That's particularly in patients who are, HRD or homologous recombination deficiency test positive.
Yeah.
The reason that's so relevant is because the importance of that regimen in improving clinical outcomes mandates us to really understand what does the immune checkpoint add beyond the PARP inhibitor plus bevacizumab
Mm-hmm.
and in that particular patient population. So what the vulnerability here is, as we try to make sense of this data, we start to really parse out the patient populations into smaller and smaller groups, which make it hard for us to interpret the findings of these studies. And
Yeah.
so, as we know, it's very hard in clinical trials to try to take the data at the end of the study and then work backwards to justify the population that we theoretically would have wanted to enroll.
Mm-hmm.
The integrity of the clinical trial really hinges on how was the study initially designed and what question was it intended to answer. So I will say that
Right.
yes, these trials did meet their primary endpoints, as you summarize on the slide here, but we're obligated to ask ourselves, how does that fit into the current standard of care treatment paradigm, where we are using PARP maintenance or
Mm-hmm.
PARP plus BEV maintenance? And it's unclear to us if the immunotherapy truly is adding benefit in this clinical scenario.
Yeah.
So this is still an opaque issue. We don't know how the United States Food and Drug Administration, the FDA, will view these results and look at them in terms of determining, is this truly a beneficial addition to our standard of care treatment or not? I think this overall survival issue is relevant,
Mm-hmm.
especially as we're talking about adding several drugs at a certain line of therapy. So I will say I don't know if we're going to see anything change in the front line.
Yeah.
My current perception is likely not to be the case as we look at all of the data, because we have to remember there were other trials presented, the Imagine clinical trial and also the Duo O clinical trial, and we haven't
Yeah.
seen anything come from those. So
Yeah.
it's unclear to me if we're going to see an immunotherapy in the front line based on these studies,
Yeah.
I will say.
Yeah, and even though it looks like this Keeling data is encouraging, the problem is still that it's very difficult to interpret, because the arm with pembrolizumab alone also did not show a clear benefit. So,
Correct.
it is very difficult to kind of figure out what comes from what, and adding another drug, as you say, comes with a whole other side effects and things like that. So, yeah, so maybe we can say that right now it's not clear that at least with the information we have at this time, that immune checkpoint inhibitors have a role in first line treatment of ovarian cancer.
I think it's
Yeah.
definitely fair to say that, and I don't know if there will be a role in the front line.
Yeah, that's fair. Fortunately, we saw other results. So let's move on to something on a little more upbeat note. And this is a phase 2 trial that was presented by Dr. Liu. She studied the combination that you alluded to earlier, lenvatinib and pembrolizumab, but she actually looked particularly in people that had clear cell ovarian carcinoma. And this was a phase 2 trial, but it had some really encouraging signals, overall response rate, I believe, of 37%, more than 10 months of progression-free survival. We kind of had an idea that maybe clear cell ovarian cancer is a place where we could use these types of drugs, the immune checkpoint inhibitors. Can you talk a little more to that?
Of course. So I think the relevance of this data actually hinges on the fact that we don't want to paint with too broad a brush. Not all types of ovarian cancer are identical. We know that specifically here, for example, clear cell ovarian cancers may have biomarkers that are predictive of response to immunotherapy, and we're learning more about those. So here we're saying, look, and to me, this highlights the fact that we continue need to be thoughtful. We need to test these tumors. We need to understand the molecular makeup of the tumor,
Mhm.
because there will be clear cell ovarian cancers that are mismatch repair deficient or tumor mutational burden high or have other molecular aberrations that may inform response, where a combination regimen like lenvatinib plus pembrolizumab may have good efficacy. So this is an informative phase 2 trial. It highlights the need for us to stay vigilant about the types of cancers that we're treating and to test appropriately. But of course, if we're thinking about all clear cell ovarian cancers, it will require a confirmatory study where we compare lenvatinib and pembrolizumab to other standard of care options to truly show that it would be effective across these populations. And it also obligates us to really think about the biomarkers for these patients. So when we report out data on clinical trials like this, we want to be thoughtful about the molecular makeup of these patients, which can impact these results.
Exactly. Interesting. Yeah, in this particular study, I believe that it was reported that none of these patients with clear cell ovarian cancer had the deficient mismatch repair. But of course, we need to know much more and know other biomarkers. So there's one other kind of encouraging news that came out also last month. This is another setting where we could think that maybe there could be a role for immune checkpoint inhibitors. We heard in a press release that the Keynote B96 trial also actually met both its primary and secondary endpoint. The Keynote B96 trial was a phase 3 trial for epithelial ovarian cancer, so clear cell, but also high-grade serous, endometrioid, and different types of ovarian cancer. And it investigated the treatment. We know that weekly paclitaxel alone or with bevacizumab can be a standard treatment for platinum-resistant ovarian cancer, but in this study, the experimental arm actually added pembrolizumab to this regimen. And it sounds like this result, this trial was positive, so it's going to be very exciting to hear more, hopefully soon, what this means.
Yeah, I share your excitement
Yeah,
completely. Many of us do, particularly because if we meet the endpoints for primary progression-free survival, but also if there's an overall survival improvement, that is a
exactly.
big deal in patients who have platinum-resistant recurrent ovarian cancer. So this may inform a role for immunotherapy beyond what clinicians are currently using it in the ovarian cancer space in the recurrent setting.
Hmm.
As you highlighted, this is platinum-resistant recurrent ovarian cancer, but I am super excited to see this data presented at an upcoming scientific congress, understand the benefit, and hopefully usher in another option for patients with platinum-resistant disease, where we really are eager to continue to have various treatment options that we can cycle patients through so that we can keep the disease controlled for as long a period as possible.
Exactly. Let's turn to a different type of treatment. And actually, we're staying in the platinum resistant space because at ASCO, we did actually learn about the results from another phase 3 trial, the ROSELLA trial. And this trial studied the combination of a drug called relacorilant that was combined with weekly nab-paclitaxel or Abraxane versus nab-paclitaxel alone. Um, can you tell us just a little bit about what is relacorilant?
Yeah, this is a totally novel mechanism of action. It's a glucocorticoid receptor antagonist. So think stress pathway, steroid pathway. And what we've discovered through preclinical work is that signaling through the stress pathway can actually prevent cell death. It's called apoptosis.
Hmm.
And so the thought is, look, if we're giving chemotherapy, chemotherapy is trying to drive these cancer cells to die.
Yeah.
But if that process is inhibited by stress signaling, can we block that signaling so that we can get cell death? And so the hypothesis behind this trial was if we can give a glucocorticoid receptor antagonist, a drug that blocks that stress signaling pathway, steroid signaling pathway, and chemo, can we get increased cell death? And that's exactly what we saw in this study. We saw an improvement in progression-free survival
Yep.
and overall survival.
Yeah. So quickly, so basically this is kind of the schema and the drug was given the day before, the day of, and the day after the infusion of nab-paclitaxel. And this is the results that you really alluded to. We did see a progression-free benefit, progression-free survival benefit, and we also actually saw that they reported an extension of overall survival in this combination. And it's kind of exciting to see a new treatment like this that does not require a biomarker. I know we just talked about biomarkers. Biomarkers are very important, but this particular result actually seems to work in the whole group of people that were studied in this trial. So
I
that's
echo that. It's
encouraging.
it's like we want to have both. We want to have
Yeah,
the biomarker to use when it's present, but we
yeah.
also want to have effective strategies for those patients that may not have a biomarker or a biomarker associated therapy. And you're exactly right. We're going to see how this evolves because the overall survival data that was presented was not yet mature. And
Hmm.
Dr. Olawai, who presented it, mentioned that on behalf of the study team. But this is certainly provocative, exciting data. It's actually a very similar trend to what we saw with the Mirasol study for
Mhm.
mirvetuximab and FR alpha high patients. So we're optimistic that this will ultimately give us another treatment strategy. And as I alluded to, Anameta, a moment ago, the key here is to have options for our patients with platinum-resistant recurrent ovarian cancer. And we're hopeful this will be another treatment option for these patients.
Absolutely. We'll see what the FDA says hopefully soon. And I'm gonna just turn my attention to another, go back to a biomarker targeted strategy. We've known for a long time that a proportion of people with ovarian cancer and also actually a proportion of people who have uterine cancer, endometrial cancer, have changes in the tumor cell, something called a cyclin E1 amplification. So this is what we call a gene amplification. It basically means that there are extra copies of this cyclin E gene in the cancer cells compared to in the healthy cells. And this typically results in the cancer cells having more cyclin E protein. Um, we know that cancer cells that have that going on, they typically kind of grow faster. They are able to pass quicker through what we call the cell cycle, which is kind of the process cells have to go through to kind of divide and to grow. But it kind of also stresses these cells. So we have learned over time that cancer cells that have these changes, they may also be particularly vulnerable when we block some of these important protein that are important in the cell cycle. For example, something we call the V1 or CDK2. Those are, things that are involved in this and also others. But this was kind of an exciting study presented at SGO where they looked at ovarian cancer patients, again, the platinum resistant setting, and they studied the V1 inhibitor, azenosertib. Can you kind of give us just a little more about information about this study?
Yeah, so this, to your excellent summary, Anameta, we're looking to capitalize on a vulnerability in cancer cells because cancer cells are replicating and dividing rapidly. And in doing so, they really need to be thoughtful about repairing any damage to the DNA. Well, if we prevent them from fixing that, it's like driving a car with just a gas pedal on the freeway and no brake. At
Hmm.
some point, you're going to wreck. And
Yeah,
so what we're trying to do is remove that break and so drive these cancer cells into replicative stress and cell death. And so thankfully, not only are we starting to see efficacy in these cyclin E1 or CCNE1 amplified, but we're starting to see an expansion to even those patients who may be overexpressing by something called immunohistochemistry, which is looking at the expression of the protein on the cell. And the efficacy data from these studies is showing a signal that would be very promising. When you see objective response rates better than 30% in a platinum resistant population that's pretreated, that gets us excited because,
hmm,
again, it allows us to be confident and hopeful that we'll be able to see continued efficacy as we advance this drug in development. So I'm excited to see these drugs move forward. I think we have to be very thoughtful about how we can use these drugs, how we can dose these drugs in a way which is tolerable and patients can stay on them for long periods of time. But again, this entire pathway of cyclin E1 as a target is very exciting, appealing, and we have active clinical trials looking at exactly this.
exactly. Just to kind of touch on another result, this is now one of these other drugs that are also like having a role in that same pathway. This is what we call CDK2 inhibitors, and this is a drug that's called INCB 123667. And at ASCO, they actually presented results both from the platinum-resistant ovarian cancer setting and also from a cohort of endometrial cancer patients. And the idea is the same. We have come to understand that it's not really just the people that have the amplification of cyclin E1. There is a proportion of patients that have high levels of cyclin E without having the amplification. So we need to get that biomarker testing going. So far it's still happening for people that try and enroll in the trials, but hopefully this is gonna help us like find treatments that are particularly effective in this kind of setting. So I'm going to move on to some more recurrent ovarian cancer. This E7386 study, this is another new treatment option that is being investigated for recurrent endometrial cancer. Can you talk to this?
Of course. So, we're excited to look at strategies. We've talked about immunotherapy, we've talked about DNA damage repair. We will be talking about antibody drug conjugates, but this is a not any of those strategies. This is a oral drug E7386, which targets a pathway called the Wnt beta-catenin pathway, which we know in endometrial cancer may be important to the survival of those cancer cells. and lenvatinib, a drug that I already alluded to previously, which is already being used in endometrial cancer with immunotherapy. But this is looking at this combination. And what's really driving this was a prior study, which was called a dose escalation, looking at different doses of the combination, which showed that in patients who had recurrent endometrial cancer, if you treated them with this combination, if they didn't have previous lenvatinib, the response rate, although a small number of patients, was 50%, which is very exciting. And if they did have prior lenvatinib, the response rate was still 33%, which is again exciting. So this is actually an active, ongoing clinical trial that's looking at this combination. It's a randomized study, also looking at standard of care and different doses of the study drug with lenvatinib. And so we're looking at novel combinations of agents. This is 2 oral pills, which is also very interesting. It's not an infused medication, to try to see what options we have in patients, particularly now that we're using immunotherapy in the front line, where lenvatinib and pembrolizumab doesn't make sense after prior immunotherapy. So it's looking at new strategies to try to identify effective options for patients with recurrent endometrial cancer who progressed after prior chemotherapy and immunotherapy.
Exciting. And as you mentioned, ADCs, we can't get around ADCs. I just took one of the many abstracts and brought it here just to talk about one other result in the endometrial cancer. This is a study with the folate receptor alpha targeted antibody drug conjugate, the Rina-S. We already have that in many studies for ovarian cancer, but now they also actually reported that they saw encouraging results in the endometrial cancer space. I don't know if you want to briefly mention what you
Yeah,
think about
so
that.
this to me is an example. We are seeing an explosion of antibody drug conjugate drug development. We will be learning and talking more about this over the coming year. This study, although again a small number of patients, showed at the 100 milligram per meter square dose a response rate of 50% in these endometrial cancer patients, or approximately that. So again, very exciting because we need options, and the whole goal is to continue to iteratively improve responses and give our patients treatment strategies that we can use in sequence to try to
Exactly.
control disease for a long period of time. So exciting data, informing strategies, and hopefully being able to move this into confirmatory clinical trials.
So, of course, we can, unfortunately, I would say, we cannot talk about all these many results that came out. I tried to pull together some of the trials that actually reported out at SGO and ASCO and had, cohorts or looked specifically at gynecological cancers. And you can see here lots of them. Antibody drug conjugate that have different targets, have different payload, So as you say, this is just the tip of the iceberg. There is so much going on with antibody drug conjugates. And, I think it can be confusing, but it makes me hopeful that there's basically an antibody drug conjugate for everyone because there are so many and we have so many different targets. So, and we have a lot to learn. We have to learn, how does it make sense to use this one after the other? Um, so unfortunately, yeah, it's too much to go into all of these trials, but I would say that all of these trials really were encouraging. We typically saw at least a 30% response rate in these trials in gynecological cancers, often 40% or even sometimes, as you mentioned, 50% response rates. And this is typically in earlier trials where people have had many prior therapies. So this is an area of like very, very active research. So to kind of cap that off, I just wanted to highlight that the antibody drug conjugates have also already moved into earlier clinical settings. We have talked about the platinum resistant setting. This is now ovarian cancer trials, where I just wanted to highlight what phase 3 trials are actually ongoing already. The Rina-S folate receptor alpha targeted ADC is in a phase 3 clinical trial for platinum resistant patients, and Baludotatoc, the deruxtecan, I don't know if I said that right. It's a drug that has been in a phase 2, phase 3 trial that's going to reopen later this year in the phase 3 setting. But we have also seen that some antibody drug conjugates now are moving into the platinum sensitive setting. And then they're being used for maintenance. One is mirvetuximab, that is already an approved drug in the platinum resistant setting. Um, Both mirvetuximab and sacituzumab tirumotecan are being investigated after people have had a platinum sensitive recurrence and they have finished their 6 cycles of platinum based triplet in this case, because they need to have platinum based treatment with bevacizumab. They can enroll in these trials, and they're trying to investigate it adding an ADC to bevacizumab maintenance may be more effective than bevacizumab maintenance alone. And just very recently, the Destiny Ovarian 1 trial actually started in the first line setting, kind of investigating the same thing. This is a trial specifically for people without BRCA mutations. We're trying to see if adding this ADC to bevacizumab maintenance actually may also improve the outcome in the first line setting. And in the same way, we have just so many options in the endometrial cancer space and in the cervical cancer space. Maybe you can talk a little bit to that, some
Of
of the
course.
trials you know.
So first, congratulations. You pronounced every one of them absolutely
I'm not
correctly.
sure. I'm not sure.
You did. So you'll see many of these are the same drugs. There's some different ones, sacituzumab govitecan. That's an antibody drug conjugate directed against TROP2, which is a surface molecule protein, and then DB1303. So I, not to get too much into the weeds, but essentially what we're saying is we recognize that antibody drug conjugates are likely going to have a role. We don't know for sure in the design of these trials whether it's going to require the expression of a biomarker at a certain level or not. That's being investigated in these studies. And we're also looking at it again in patients who had recurrent endometrial cancer after prior chemotherapy and immunotherapy. So very similar to the combination I mentioned, the E7386 plus lenvatinib. But in that space, here we're looking at antibody drug conjugates, or potentially in the first line with trastuzumab deruxtecan, again, trying to take advantage of a signal that we saw with the Destiny Pan-Tumor 02 in the recurrent setting to see if we move this up into earlier lines of therapy, can we get a response that improves clinical outcomes in these patients?
Again, in the people, of course, that have the right biomarker in this case.
Correct.
Yes.
Understanding whether or not and what level of that biomarker might matter. So
Yeah,
that's going to be
exactly.
integrated in the design.
Yeah.
And then in cervical cancer, the same again, antibody drug conjugate, sacituzumab tirumotecan or SAC-TMT. That's being looked at in patients who receive systemic chemotherapy with immunotherapy and or with or without bevacizumab who progress are being randomized to this antibody drug conjugate versus physician's choice, which actually includes an already approved antibody drug conjugate tisotumab vedotin. So it is, we say, an ADC world. We're eager to see how this is going to evolve. We have a lot to learn about biomarkers, about selection, about sequencing, Anameta, to your point. But we are so excited because based on the previous preliminary data, we're optimistic that these will be positive trials,
Absolutely.
giving us additional options.
And so much going on and probably more coming also of this soon. Yeah. Great. I am gonna go to my last subject. I know your favorite subject. There were a lot of trials both at SGO and at ASCO that used what we call circulating tumor DNA, or we also sometimes call it liquid biopsies, to kind of monitor, to follow how people were doing. This is just one example where they presented some data. Some of the patients in this Duo E trial, they actually had been able to follow with testing their circulating tumor DNA at diagnosis, during the treatment, and after treatment. And they used this tool as a way to kind of monitor how the different treatments work. This is an area where my sense is that a lot of patients start to request this. They are interested in having this tool as a very sensitive means of monitoring if they potentially are experiencing a recurrence. But I also hear that there's a lot of pushback among physicians. Can you kind of talk to that? I think it is a complicated situation.
So complicated, but also an important question. One, honestly, that I have with patients, at least on a weekly basis, I feel now.
Hmm.
We're learning more about the relevance of circulating tumor or ctDNA. I congratulate Dr. Weston and the team because they're reporting on the data, looking at changes in ctDNA for patients that were treated on clinical trial.
Hmm.
The real question we always have to ask ourselves is, what is the clinical utility? What am I going to do with the information
Yeah.
about ctDNA? Because the value of information is when we know that we can use it to improve outcomes for our patients. If I have a piece of information and I don't know what to do with it, and I don't know what it means biologically for the patient, it can create a substantial amount of stress without really informing management. So where we are right now with ctDNA in GYN and gynecologic malignancies is we are working to figure out how can we design the right clinical trials to use ctDNA to inform treatment to improve clinical outcomes.
Mhm.
In clinical practice right now, if we order a ctDNA test, we may get a result, but it's very hard for us to understand, what do I do with that data? Do I somehow use this to escalate a treatment? Do I use it to de-escalate a treatment if it's negative? Do I
Mhm.
use it to identify a recurrence? We don't know, and we don't know what it means. What does a positive test mean right now in clinical practice? So I know there's a lot of momentum and excitement about this, which I am happy to see, but I also just say we have to do this in a thoughtful way. We have to understand, how can we use this data to design clinical trials that then answer questions and improve the outcomes for our patients. Because at the end of the day, that's what all of this is about,
Of course.
is improving clinical outcomes. So I think right now it's very early. We're very nascent in the understanding of ctDNA and what we're going to do to manage patients. But in the same breath, we're becoming much more thoughtful about how we incorporate this in future studies so that
Yes.
we can use this data to guide treatment strategies.
Great. I think that's a good place to stop, sorry. And I just want to thank you
And
again.
start. Good place to
For,
stop and start.
I
Yes.
know. Yeah, I just want to thank you again for joining me today. It was I learned a lot, and I think it's just a really exciting time with so many new things. So thank you, Ramez, and talk to you again soon.
Thank you for having me. It was a pleasure to be here.